This is an educational video from Precision Analytical, and it's a part of a series we are calling the Caveat series. And what we're doing in this series is we're just looking at each test and what the weaknesses are of that test. We're going to look at serum testing. In this video, we'll look at saliva. And to be fair, we're also taking a very critical look at urine testing, which is what we use, and very specifically the Dutch model, the dried urine test for comprehensive hormones. That specific model, we're going to look at the weaknesses and issues that can be related to that test as well. So do see that video as well. But in this one, we're going to focus on saliva testing. So when you're looking at your different options, one of the issues with any of these tests, and that's why we developed the Dutch model, is you just get more information with that model. But in this video, we're going to really look at a number of other issues, not just what are you testing, but what are some of the issues that can catch us up and really create a situation where the data that we're getting is not as helpful as it should be. So when we're looking at saliva, one big missing piece is the cortisol metabolites. We'll look at that here in a second. A second really important point is as you look at the data in the saliva industry, the testing is fine in terms of accuracy for many of the hormones. But estradiol particularly, and the other estrogens as well, but we'll focus on estradiol, the testing really is lacking in terms of accuracy. That's analytical accuracy. And the testing is prone to cross-reactivity problems. That's something you need to watch out for. Doesn't mean you can't use saliva testing, but you need to be aware of this problem. For example, if estriol is really high, it can actually increase your estradiol levels artificially. If 7-keto-DHEA is used, it can actually react with the test, meaning if I take a vial that only has 7-keto-DHEA in it and I get it tested with a saliva lab for DHEA-S, for testosterone, the more 7-keto-DHEA you put in that vial, the higher the DHEA-S and testosterone values will go, even though there's none in there. So it's a cross-reactivity. You've got to be careful with that. I've seen situations with aromatase inhibitors that look a lot like testosterone, hugely increasing salivary testosterone values. So be aware that when a molecule looks the same as the thing you're testing, if there's a lot of it, it can increase the salivary result. And here's an example. This patient tested saliva, estradiol, and estriol. Okay? The first value, we're looking at 1 milligram of topical estrogen. So that's half estradiol, half estriol. The second time around, same thing. Look what happens to the values. The first time, this estradiol value is right in the middle of the premenopausal range, and the estriol value is right where you'd expect it to be given the supplementation. Okay? Then she collects again, and her estradiol has gone up a lot, and her estriol has gone up a whole bunch. So what's going on? It's not a contamination situation with her supplement, because this supplement has even parts estradiol and estriol. If you contaminate it with the actual cream, then the estradiol is going to go up just as much as the estriol, and it doesn't. In this particular case, she started using an estriol facial cream. Okay, so what happens there is you get these huge numbers, not because she has huge levels of circulating estriol. When you look at this little informal study where one individual put on topical testosterone in different locations and then measured the maximum salivary values, the area around the clavicle, so up around the neck area, gave a huge value. The forearm, somewhat less. And look at that scale. It's a logarithmic scale, right? So it's a huge difference as you go away from the saliva gland. So what happens if you put estriol on your face? The saliva is going to be hugely affected. You get lots of estriol. It doesn't really have any clinical significance, but here's the problem. Estriol cross-reacts with the test for estradiol at about 0.5%. So if you take 0.5% of this, you get about 6.5. And when you add that value on here, that change is not real. The amount of estradiol in that sample has not increased to the degree that you see here. It's the estriol artificially creating that. And that's a particular problem with saliva testing that you need to be careful of. If you take a sublingual progesterone and you test right afterwards and you test testosterone, it can really increase the testosterone value artificially. So, back to our main list of caveats here. cortisol testing is missing the metabolites. This is a really good example. These two patients, if we're looking at the free cortisol in urine and saliva, we should get a similar pattern. So in the morning, we have two patients. Okay, the reference range is between these two black spots or lines, and the patient value is then in red. So the patient value is low. In the afternoon, the value is low. At bedtime, it's about where it belongs, and in the waking sample, it's also on the low side. So the free cortisol is relatively low. If we look at patient number 2, the free cortisol is also relatively low. Now, if you were looking just at the free cortisol, they're pretty comparable, and actually the bottom patient actually has a little bit more cortisol. Now let's shift over from free cortisol and look at the metabolites, which are really a better marker of overall production of cortisol. Remember, free cortisol represents 1 to 3% of the total. It's important because that's what's circulating. But in terms of production, it's only 1 to 3%. The metabolites represent more like 60, 70, 80% of the total. Look how big these numbers are. These numbers are in the same units. Okay, so that's your better marker for cortisol production. These two patients who look very similar in free cortisol are very, very different. Okay, this top patient is obese, and obesity increases cortisol production, but it also increases cortisol clearance. So now you've got this dichotomous situation where the production is very, very high, but the circulating cortisol may not be that high. The bottom case is somebody who is actually taking a glucocorticoid, which had suppressed their cortisol, so the free cortisol looks low, and then when you measure the metabolites, you confirm that conclusion that indeed the cortisol production and the circulating cortisol is all low. But in the top case, the situation clinically is very, very different than the bottom case. Do you want to treat these two patients the same? Absolutely not. But if you're doing saliva testing, you may do that. In the top case, again, she's obese and that's what's causing it. If you look at the data on obesity and cortisol, free cortisol in saliva, free cortisol in urine, there's either no correlation or a slightly negative correlation, meaning the bigger and the more adipose tissue that a patient has, those numbers actually get a little bit lower. But if you look at the metabolites, which is what this bottom study did, and you look at that, there's this huge positive relationship. So that doesn't mean the metabolites are more important. What it means is you need both bits of information to characterize well the patient with respect to cortisol. And that's why the Dutch model is strong, and that's a missing piece for saliva. Secondly, the estrogen testing is lacking accuracy. This doesn't mean the actual amount of estrogen in your saliva is a bad number to have. What it means is the analytical methods, which are okay for progesterone, they're not sensitive enough for estradiol. Let's look at this. Here's a woman and her serum throughout the cycle. So she starts off relatively low, and then she hits this peak at ovulation. That's the ovulatory peak. And if you look at that number, it actually gets her outside the premenopausal range. Then the levels come back down, and they go up and down a little bit within that luteal phase. The postmenopausal range is way down here, meaning because she's premenopausal, all this action happens above that postmenopausal range, and she even gets outside the premenopausal range. When you look at the same day urine collections, you get the same thing. You get this big ovulatory peak that's outside the premenopausal range, and the postmenopausal range is lower than all of this action happening within that menstrual cycle in a premenopausal woman. This makes sense. The urine and the serum tell a very similar story. When you look at saliva, we sent this to 7 different labs actually, and we see 6 of them here. What we found is that for 6 out of 7 labs, none of these points were above the postmenopausal range. So for lab number 1, the postmenopausal range was right here. That was the limit of it. So under here is the postmenopausal range. The ovulatory peak doesn't even get out of a range that you're defining to be estrogen deficient women. With this lab over here, the postmenopausal range ended right there. Again, that peak is not well defined. In saliva lab number 2, you don't even see the peak. Right? There's really nothing there. That peak should rightly be way up higher. Right? Saliva lab 4, same thing, the postmenopausal range. Saliva lab 6, not close at all to where it should be. And saliva lab number 5 was the only one where the postmenopausal range was right here. Meaning it snuck its head out a little bit outside that postmenopausal range, but the premenopausal range ended at 16, meaning it really should, that result should rightly be way up there, and that's the best that there was to offer. So most of the labs showed actually good results for progesterone. But for the estrogen, you just don't see that differentiation between a state of deficiency, a state of sufficiency, and a state of excess. When you look in blood and you look in urine, you could see those patterns, and they parallel each other very, very nicely. So the analytical accuracy is just not there for commercially available salivary estradiol tests. Now, shifting slightly to supplementation, there are some significant caveats when you're trying to monitor supplementation with salivary testing. The first one is very obvious: sublingual hormones. If I take a milligram of a hormone, that's 1 billion picograms, and those are the units we find, for example, estradiol. Estradiol in a postmenopausal woman in saliva is around 1. When you put 1 milligram in your mouth, that's 1 billion, right? So that has to clear out of your mouth entirely before the saliva numbers become relevant again. Some saliva labs will tell you to wait 30 hours and then do your test. That's not useful information. That's either going to give you a baseline value, or if the value is not at baseline and it's elevated, it's going to be residual contamination from the hormone that went right into your mouth. If you're trying to evaluate the therapy, neither of those numbers are going to be useful. Saliva testing just isn't a good match for sublingual hormones. With oral progesterone, it's also not a great match because the hormone clears out much faster than what you can see in saliva. So let me just show you this in real life. Here's the same woman we looked at before. Let's look at 3 of her tests. 1, 2, 3. She's taking anywhere between 140 and 340 milligrams of oral progesterone. Look at her progesterone values. Okay, the one where she took the most actually has the lowest value. The reason for this is that the hormone goes up and down very quickly and gets out of there. If you take it at bedtime and you collect in the morning, it's not really supposed to be there. So using a morning progesterone value is clinically not a valid concept. So it can be very misleading, and we don't want to do that. Okay, here's the range. So the Saliva Lab says that progesterone should be 100 to 300 milligrams, which is about where she's at. She's even outside that. The range should be 30 to 300. So she finds herself at the bottom of that range and not getting higher with dosing. Why doesn't it get higher with dosing? Because, again, it clears out way too fast. And speaking of clearing out too fast, that can be an issue with vaginal hormones as well. Now, these results are serum results, but it shows the issue here is when you look at these two people, these two lines here are throughout the day when they don't take hormones. So ignore those. Okay, the other two are a person here and person number 2 here. They're taking vaginal testosterone and they're measuring it over time. What we notice is that person number 1 peaks around 8 hours and then starts to go down. Person number 2 peaks around 3 hours and is, if you'll notice, back to baseline at about 8 hours. So then when do you test these patients? Now this is with the same product, right? So if you're working with different types of products, different types of bases, different concentrations, and different hormones, you really don't know where the peak is and where the trough is. So you need to be careful. Doesn't mean you can't use the tests, but if you get a low number, for example, you just simply don't know. Did I miss the peak? Or does she actually need more hormone? And there's so much uncertainty with that I find that the Dutch model works a lot better in these sorts of situations where there's an up and down to the results. Now, with transdermal hormones, what we find is that this also is not an effective monitoring tool, and this is a very complex issue. And if you want more data on this, you can watch our longer video. But let me just show you 2 of the issues with that. In this particular patient, what we saw, and we've already gone over this in some detail, is that the estriol was very, very high, and what we said is it depends on where you put it. Now, if the hormone is very different depending on where you put it in relationship to the saliva gland, that really tells us that the mechanism by which the hormone is getting to the saliva is not really what I think we've thought for a long time, which was that the hormone gets into circulation and that free hormone ends up in the saliva gland. What this implies is that there's more of a diffusion of some sort of the saliva getting full of hormones, and that doesn't really make it a very good monitoring tool. But the data that really I think is critical here is when we look at multiple samples collected. In this particular study, what we have is we have 12 people, and they're taking topical progesterone. So they put 80 milligrams in a controlled study on their thighs, and they took it for 2 weeks, and then they tested, and then they tested again. And these two collections were both 24 hours after supplementation on 2 different days. And so we need to get reasonable reproducibility if we're going to change a dose based on these numbers. So if you look at person number 1, they get in saliva about a 400 and then about a 900. Person number 2 is around 2,000 and then 900. Person number 3, and this is where we really start to see these huge swings, is she's at almost 7,000 on the first day. So then the next day she collects again, both of these 24 hours after supplementation, and she's more than 10 times lower. So then which of these values would you adjust the dose based upon? It doesn't make sense to adjust the dose based on either of these values, knowing how variable these are. In this study, it was most common for somebody to differ from one collection to the next by a factor of 5 or more, and there are other issues to sort of work through in terms of whether this represents systemic exposure to hormone, but at its most basic level, if we don't have clinical precision or reproducibility, then we can't go around changing dosages based on these values. So as we work through saliva testing in some of the strengths and weaknesses, for the sex hormones, we've got some issues in terms of accuracy, but it's also, in fairness, important that we note that with progesterone, that's not really an issue. DHEA shouldn't be an issue. Cortisol shouldn't be an issue in terms of accuracy. Testosterone a little bit, but estradiol is really problematic. When you get to the adrenals, we're missing the metabolites, and that's an issue. Oral progesterone's not going to work well. The estrogens, when you want to look at them when you're supplementing orally, that works okay. You're just still limited by the lack of accuracy. But that can work okay in terms of conceptually. With vaginal hormones, again, the change of hormone, the up and down, is a little bit unpredictable. With patches, pellets, and injections, I think saliva can work really well. Sublingual hormones, that definitely doesn't work because of the contamination. And then you've got this big topic of transdermal hormones that's quite complex. And again, I would watch the video that we have on that elsewhere that really goes through it in detail if you have some more questions on that, because it's a pretty complex topic. But the main caveats, the cortisol, the estrogen, and then just to be aware that there can be some significant cross-reactivity issues there. And then with supplementation, really sublingual, oral progesterone, and vaginal hormones can be problematic. And overall, that's really why we developed the Dutch test, is to try to improve on some of these deficiencies where there is a lack of clinical significance to the values that you're getting in a given scenario because of either missing information or because of some weaknesses as it relates to monitoring supplementation. So I hope that's been helpful. Again, please do see the rest of the series so you can see and understand the weaknesses of not just saliva testing, but also the testing model that we're using and serum testing, so that we can collectively make good decisions for patients going forward. And we thank you for your time.